Next up will be Dr. Jabbour, who you all met just about an hour or two ago. So she'll be talking a little bit about how to synergize between radiation and systemic treatments.
Thank you again for the opportunity to speak with everyone once more. Disclosures. So we'll start with a case, keep it interesting. Remember, you have to raise your hands this time. So this is a 68-year-old man with a 60-pack-year smoking history and a 2-month history of cough and small amounts of hemoptysis. On chest CT, there's a right hilar mass about 4 centimeters and adenopathy that extends proximally encasing the pulmonary artery and right level 4 and 7 lymph nodes. Can take a look at the tumor there. I don't have the ability to point, I don't think so. And on PET scan, we can see the mass there. There's adjacent right hilar invasion abutting the wall of the right main pulmonary artery, approaching the carina, ipsilateral right hilar and right mediastinal lymph node metastases, and this is in the 8th edition, a 3B. There's no distant disease. And on EBUS, the mass is obstructing the right main stem bronchus. The right mass is biopsied and the right upper lobe is opened. 10L and 7 are positive for poorly differentiated invasive squamous cell carcinoma. PD-L1 is 5%. No driver mutations. Brain MRI is negative. So here we go. Ready? So choice A, induction chemotherapy and immunotherapy followed by surgery. Who's voting for this? All right, surgery followed by postoperative chemotherapy and immunotherapy. Oh, guys, okay, come on, help me out. Chemoradiation and consolidation immunotherapy. Thank you, Henning. Thank you. All right, induction chemotherapy followed by chemoradiation followed by consolidation immunotherapy. Thank you, Jonathan. Okay, so what we're going to talk about today, so the landscape of stage 3 non-small cell lung cancer, improving PFS and OS and biomarker-selected stage 3 locally advanced non-small cell lung cancer, and chemo-free and potentially novel options for locally advanced unresectable non-small cell. So I'm not really spanning the stage spectrum, but it is mostly on stage 3. So these are kind of the preclinical data that we used to use to think about this disease, and the idea that radiation can activate an immune response, elevate PD-L1 levels, bring in many cytokines and tumor-infiltrating lymphocytes and macrophages, and increase antigen presentation. RTOG 0617 formed the standard of care for stage 3 non-small cell lung cancer. As you know, this was a high versus standard dose radiation trial looking at 60 versus 74 gray with concurrent carbotaxol and 2 cycles of consolidation chemotherapy. And we saw median survival rates of about 23 months. And this showed that when we used 60 gray, the 5-year survival rates were actually improved to 32% from 23% over 74 gray. And we were faced with the same issues that I sort of presented even in the stage 1 setting, is that there's a predominance of distant failure, and this really begged the question, can we do more? We also had data from the PROCLAIM study. This is nearly 600 patients in the non-squamous setting of cis-etoposide versus cis-pemetrexed, induction therapy followed by concurrent therapy with those agents, and survivals were a little better in the pemetrexed cisplatin arm, but there were lower adverse events compared to cisplatin etoposide. And then we obviously move into the modern era where we've seen that there's been a dramatic improvement in our ability to help the stage 3 patients, and obviously now this is even more of a mixed bag with stage 3 patients who are operable. But really, the pivotal timings were the RTOG studies, and of course, our modern Pacific data. This study, of course, you're quite familiar with, 713 patients, 2-to-1 randomization to 1 year of adjuvant durvalumab if stable disease after chemoradiation therapy, primary endpoints of PFS and OS, which have long read out and are dramatically better for our patients, and so here we are. We do have some gaps in our knowledge. Obviously, we know that the PD-L1 low patients don't seem to benefit as much. We also know, obviously, driver mutation patients may not benefit as much as well, although we did hear good data this morning about using immunotherapy in EGFR patients, and that was exciting to hear. We know that many patients don't go on to get consolidation durva for a variety of reasons, whether it's age or comorbidities or more advanced disease. And so for that reason, we started to look at this idea of concurrent immunotherapy. We did this study at Rutgers in combination with my colleagues at Penn and Yale, and we were able to conduct this study safely and found that there was potentially a synergy of the therapies, and this went on to the Keynote 799 phase 2 trial. These was a non-randomized phase 2 study of stage 3 patients who got induction immunotherapy plus chemotherapy, either with pembrolizumab and paclitaxel and carboplatin in cohort A for squamous and non-squamous non-small cell lung cancer, or in cohort B, where they got pemetrexed and cisplatin plus pembro, and then were followed with those same agents in chemoradiation and then maintenance pembrolizumab. And this had 18 patients in it, and we can see that most patients, many patients were able to continue treatment, complete treatment, but obviously these are toxic therapies. We didn't really get into the toxicity of chemoradiation alone, but they're not easy therapies, although we have many modern ways to get patients through therapies better. In general, these are kind of standard baseline demographics of the patients who are in their mid-60s. Obviously, a wide range of ages there. You can see the FEV1s percentages were pretty good overall, and we did have a good percentage of patients, about 30% who were PD-L1 low. Overall tumor response, the objective response rate in cohort A was almost 72%, 71.4%, and in cohort B, 75.5%. And most patients really did not progress. So in these patients, there was only a couple of progressors, and the median duration of response was about 4 years in both groups. And I think it is interesting, although they are very small numbers, so hard to generalize, but I will highlight that the objective response rate did seem even favorable in those who were technically PD-L1 low and seemed to be present regardless of histology. The time to response was about 2 months in both groups, and you can see the duration of response was often prolonged. The progression-free survival at this final analysis for the cohort A, the median PFS was 29 months, and in cohort B was 45.3 months. And overall survival, about 3 years in cohort A, and approaching almost 5 years in cohort B. And obviously there could be some hypotheses about this, particularly the fact that cisplatin pemetrexed may be a better systemic agent. We don't really 100% know. Also, these obviously were all non-squamous in cohort B, non-squamous patients, so there could be a lot of explanations for this. We know these, again, are not without toxicity. All these patients got basically quadruple therapy with radiation, chemotherapy, doublet, plus immunotherapy, and so we have the expected toxicities that are highlighted here. And also, immune-related toxicities, which in cohort A was about 7% for grade 3 or higher pneumonitis, and in cohort B was about 8% for pneumonitis. So these are the kind of all grades, all comers. We have this follow-up study, Key-Link 012, which has finished accruing and has not yet read out. This asks the same question as in Keynote 799, obviously with the comparator standard arm of the Pacific trial in cohort C. And in the middle arm, there is an olaparib consolidation, and that is because of some preclinical data suggesting potential benefit. And we had some negative studies that read out, regrettably, also Pacific 2, asking the question of concurrent durvalumab, also negative, and Checkmate 73L, also regrettably negative. And ECOG 5181, asking the question, obviously with durvalumab, still waiting to read out. I do think the results will come out soon. So we have mixed results in the stage 3 setting, combining concurrent immunotherapy with radiation therapy, although some things coming down the pike that may further inform our care for these patients. But what about biomarkers selected stage 3 locally advanced non-small cell lung cancer? So these would be genomically driven tumors we can treat. Obviously, here we have the LAURA study, osimertinib indefinitely after chemoradiation for EGFR mutated unresectable stage 3 disease. Again, a 2-to-1 randomization for osimertinib versus placebo after stable disease with chemoradiation, and dramatic benefit in PFS that we saw come out over a year ago, nearly 40 months versus 6 months to go on adjuvant osimertinib if there is an EGFR mutation. This is how I think about it. I know I'm a radiation oncologist, but I have to think, why are we incorporating some drugs into this paradigm sooner than others? Partially it is obviously the incidence being more common, but I also think many of the drugs still aren't completely ready for prime time, although newer generation drugs are certainly, have certainly been coming out and are coming into clinical trials. I think there's still more to be done in terms of our knowledge here, and I think obviously some of these drugs are far more superior in terms of their efficacy than some of the earlier generation drugs. Here's a real-world study of consolidation ALK tyrosine kinase inhibitors versus durva, or observation after chemoradiation in unresectable stage 3 ALK-positive non-small cell lung cancer. It's a small study, but still interesting to look at these results. This was actually a pooled analysis from multiple institutions, and it amounted to about 70 patients, 67 patients. You can see about 15 patients got the ALK TKIs, and then about half and half, about 30 patients in each got observation or durva. And really there was a huge benefit to having the ALK inhibitor incorporated after chemoradiation as opposed to durva, so analogous to what we sort of know in the osimertinib EGFR landscape. This is a really unique study being done by my colleague at MSK, Dr. Narek Shervaridian, who is looking at using a KRAS G12C drug after chemoradiation and is doing an early time point, around, I think about cycle 3 of durva, where he obtains ctDNA, and if there is a high ctDNA level, transitioning patients to a KRAS drug and sotorasib instead of durva. And we did see kind of, again, a signal for ctDNA even in 799. This was a subgroup analysis of patients who did have ctDNA drawn that we presented at ASCO 2024. These patients who cleared their ctDNA at cycle 7 had far superior survivals to patients who didn't clear their ctDNA. So again, really hinging on your last talk, suggesting that, what do we do when patients are really kind of turning up negative with their disease, and can we stop therapy sooner? Can we do something different? Really asks some interesting questions. We saw a similar pattern in another study I participated in. We participated in at Rutgers, looking at Nivo versus Nivo-IPI. This will be published soon for 6 months after chemoradiation. This was through the Big Ten Cancer Research Consortium. And obviously a similar pattern where in the yellow lines, the ctDNA predicted the patient's recurrence. And on the left, those pictures are my patient who kind of had this chronic pleural effusion and really lived with it until she succumbed to COVID and not her disease, and she remains ctDNA negative. Whoops, this isn't moving. All right, so what do we know? So for the stage 3 biomarker selected patients, we know from the LAURA study that maybe oncogenic drivers can receive their respective targeted therapy with a moderate to high PFS. We could also potentially apply this for patients who are not good candidates for certain chemotherapies, or maybe better candidates for checkpoint inhibitors. And I feel like ctDNA guidance could, in the radiation oncology field, give us the opportunity to think about intensification in new ways, which is in the NRG LU008 approach, using an SBRT boost, or how about thinking about a neoadjuvant approach, as was suggested by Dr. Ford earlier, to even think about treating disease earlier, or even thinking about using ctDNA to determine the duration of our consolidative therapies that are going on forever and ever, such as in the LAURA study. We have platform studies that will look at biomarker-driven defined patient populations, and we'll be excited to see those results. All right, so looking at chemo-free and novel options for locally advanced non-small cell lung cancer, we know that immunotherapy alone, such as pembrolizumab, can be an effective therapy for patients who have PD-L1 high disease. And these are 2 studies, one done by my colleague Dr. Nitin Ori at Montefiore Einstein Medical Center, looking at pembro for 3 cycles, in patients who were PD-L1 TPS greater than or equal to 50%, followed by hypofractionated radiation therapy that was PET-directed, meaning if the tumor shrunk, they would sort of treat what was still PET positive, followed by an additional 13 cycles of pembro. And you could see, actually, those aren't bad-looking PFS rates for patients who never get chemo. In contrast, the Dolphin study out of Asia, this one looked at actually 60 gray with durva, so long course radiation therapy followed by more durva, and also actually not dissimilar looking curves. PD-L1 in this case was greater than or equal to 1. And just a reminder that these PFSs certainly don't look bad if we sort of use the Pacific trial as a landmark. The toxicity profiles were far better for the SPRINT trial, where first the radiation was dose adapted and shorter course and sequential, as opposed to the concurrent and longer course given in the Dolphin, so less pneumonitis. So going back to our case. Okay, you have to raise your hands this time. 58-year-old man. Actually, it was 68. I changed the age to make it a little more, little different. 68-year-old man with a 60-pack year smoking history, right hilar mass, and we saw the scans here. Kind of this large right hilar mass. We can see the subcarinal node is positive. I think I would say right level 4 looks a little concerning. And they had also biopsied left level, I think 11 node or 10 node that I think I didn't really clearly mention. So treatment options now, induction chemo and immunotherapy. So this was followed by surgery. All right, nice, Henning. Surgery followed by a post-operative chemo and immunotherapy. Oh my gosh. All right, postprandial. Chemo radiation followed by consolidation immuno. All right, yay. All right, good job. Induction chemo followed by chemo radiation and consolidation immuno. Okay, well, this patient actually went on a clinical trial and did get induction chemotherapy and IO on a clinical trial, and you could see the tumor actually started to respond. There was a little room in his right main stem bronchus there. And we simmed him at baseline. You could see there was some nice decrease in his tumor mass by week 5 of chemoradiation. That's our radiation plan. And after consolidation immunotherapy, it looks like he pretty much had quite a good response. So in summary, take-home messages for today include that combining immunotherapy and radiation therapy can increase immune activation. Definitive chemoradiation therapy approaches with concurrent immunotherapy, PD-1 therapies are promising, and we still need our trials to finish reading out. Improving the PFS and OS and biomarkers selected stage 3 locally advanced non-small cell is important, and I think this will continue to be the way to personalize therapy along with other biomarkers such as ctDNA. And I would continue to argue for continued strategies of novel therapies, such as chemo-free options, or even sequencing some of the therapies that were described in prior clinical trials from the prior talk, such as vaccines or even more toxic systemic therapies as long as they're given sequentially. Thank you.